Good morning and good afternoon, and welcome to a strategic approach to patient engagement, a complimentary webinar from healthsystemcio.com sponsored by Relay Health. Some housekeeping before we begin. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com. I'll be your moderator today. We encourage questions. You can send them in at any time by typing them into the lower right-hand corner of your screen, the Q&A box, and leave the default set to all panelists. I encourage you to send them in at any time, but we will take them later in the program. We've already got a question about the deck, and you see the URL there before you. There's also a shortened URL at the bottom of all the slides, and I'll send it out in the chat box in just a few minutes, so you'll be able to download that right away. We will have an archive available of this event, usually within 2 business days, and a separate registration is required. You'll receive an email when it's ready. Just to give you some idea how we're going to spend our time today, we're going to go about 45 minutes. First, we're going to hear from Jeff Pearson, VP CIO at Trinity Mother Frances Hospitals and Clinics. Then we're going to hear from our sponsor, represented by Doug Bean, VP of Patient Engagement at Relay Health, and then we'll do our Q&A with Jeff. So without further delay, I'm going to turn it over to Jeff Pearson. Jeff?
Great. Thank you very much, Anthony. I really appreciate this opportunity and look forward to covering my topic with everybody. As Anthony said, I'm Jeff Pearson. I'm the VP and CIO of Trinity Mother Frances in Tyler, Texas. I joined Trinity Mother Frances in April of 2012, and previously was with Bon Secours Health System, most recently as the local market CIO for the Richmond, Virginia market. I want to tell you a little bit more about Trinity Mother Frances. We are a little over 75 years old. We're built by the Sisters of the Holy Family of Nazareth in Tyler. One day, we opened a day early when tragedy befell New London, Texas, when there was a school explosion, and we opened to take care of the family and the children of that tragedy. We came together as a health system in 1995 when we merged with the area's largest multi-specialty clinic, the Trinity Clinic. We currently serve about 1.2 million people in a 27-county area between Dallas and Shreveport. We have about 4,000 employees and about 700 providers across multiple specialties that are credentialed at our hospitals. And we went live, and I'll talk a little bit about this, on our EMR as an integrated EMR in 2012. So a little bit more about our specific entities. Mother Frances Hospital in Tyler is our mothership. The hospital itself was a 404-bed acute care facility with a multi-specialty and a trauma center. It's been expanded by the addition of a wing that we call the Lewis and Peaches Owen Heart Hospital. Operates under the same tax ID as the main hospital, but very much a distinct entity that we market in the region. Added 72 beds in December 2012. The Mother Frances Hospital has been recognized 3 of the last 4 years as a Truven Health Analytics 100 top hospitals, and the Lewis and Peaches Owen Heart Hospital is recently recognized as a 50 top cardiovascular facility, which we're very proud of to achieve that so quickly after its opening. Also embedded inside that main hospital is a partnership with a long-term acute care facility called Tyler Continue Care, and all 3 of those entities are live on our are serviced by our EMR, as are the next 2 entities, which are 2 25-bed critical access hospitals, one about an hour south and one about an hour north of Tyler. And of course, our EMR also extends to the Trinity Clinic, which is a large clinic. It's 350 providers, mid-levels and physicians. We have 36 locations, 39 specialties. Much of that clinic is the hospital-based. Within the facility are radiologists, anesthesiologists, neonatologists, ER physicians, hospitalists, currently inside of that Trinity Clinic. And then last but not least, we have a partnership with HealthSouth to operate a rehabilitation hospital in the city of Tyler. That entity is not on the not on our EMR. That is on HealthSouth's EMR. Our Trinity clinic, to the right, you see that have NCQA medical home certification for all of our providers in all of our primary care providers in that clinic. Next slide. So what I'm here to talk to you about is patient engagement, and I thought this was a good summary of overall patient engagement and what we should be thinking about in healthcare. Realizing that more and more we're finding we can't be successful in delivering high-quality care unless the patients do their part, and finding a way to achieve that both with kind of high-touch care that we provide when we see the patients face-to-face, but also how can we extend technology in order to help make them partners in their care. I think this next slide kind of touches on that here as well. It shows kind of how independent tools for ongoing self-management can be used by patients and used broadly, certainly by all patients, but might be a good focus area for our low-risk patient groups. Patient engagement can also, of course, take you into the area of the broader topic of population health management and how we engage our patients, high-risk patients, in compliance with medications, attendance at their follow-up appointments, getting the necessary testing done, and so forth, through the use of nurse navigators or care coordinators. I'm not going to be talking very much about that today, but I just did want to recognize that that's a key component to patient engagement and can certainly answer any questions you may have on how we're doing that kind of things in the Q&A period. What I did want to focus on, and I'll start getting into this in a second, is how we are focusing on primarily the use of our portal product to engage our patients, and how we are using that portal product to help us meet meaningful use requirements, and specifically how we've recently completed our Stage 2 reporting period for our most of our eligible providers, and it was a very useful tool for helping us get there. So let's start just covering at a high level what the meaningful use requirements are in the area of patient engagement specifically. In Stage 1, the rules were pretty straightforward, just simply being able to provide an electronic copy of health information to patients, and we crossed that bar pretty easily after our go-live of our EMR. What I've been calling to internally here a Stage 1.5 of meaningful use, which really is the Stage 1 with the 2014 requirements added on, meant that we needed to focus on the view, download, and transmit measure, that we make sure that not only our eligible provider patients, but also our patients that are discharged from the hospital or the ED are provided timely access to their health information. And then finally, in Stage 2, these are expanded even further into additional requirement under view, download, and transmit, that we have 5% or more of patients in those areas that actually engage, they actually view or download and transmit from the record, that 5% of those patients actually engage with us themselves by initiating a secure message through our messaging portal, and that we are using the tool to remind patients that have clinically relevant, based on some clinically relevant criteria, that we are sending them reminders for preventative or follow-up care. And I'll touch on these in a little bit after I tell you a little bit about our journey through meaningful use. We went live with our EMR in September of 2012. The EMR go-live at that point was for our revenue cycle, our radiology, and our ambulatory clinics, and we did a big bang of all 36 of those ambulatory clinic locations that I mentioned. We immediately were preparing ourselves that if we wanted to attest for meaningful use Stage 1 in the 2012 program year, we had to begin our attestation period or measurement period immediately. And we did do that, and were successful despite virtually no ramp up in the preparation and measurement. We were able to bring 86% of our eligible providers across the finish line to achieve that. So that started then for the 2013 program year for the EPs, a 365-day reporting period in 2013. We went live in our hospitals with the CPOE, our clinical documentation, pharmacy, and our emergency departments in December of 2012 in the main hospital and the Jacksonville Hospital. We went live in March of 2013 in the Winnsboro Hospital, and immediately went into the reporting period for the 90-day for the eligible hospitals, stage 1, year 1, and we did that in before the end of June in 2013, which allowed us to accrue money within that fiscal year for meaningful use. So as I said, we then did stage 1, year 2 for the EPs over the course of last year. I'm sorry, that should say 12/31/13 is the end of that reporting period. And then we are currently, we had just wrapped up our 90-day, or 1 quarter, I should say, attestation period for both the hospital stage 1, year 2, and this is our first go-around with stage 2 on the eligible providers. We did stage 2, year 1 on those eligible providers, and of the ones we had that were eligible and being measured in that time period, 109 physicians, we had 103 successfully be prepared for stage 2 attestation, which we're actually physically attesting for now. So let's talk a little bit about our patient portal journey, how it fits in that. And our approach to the portal was to incrementally add components to the portal. We expected that would be more digestible for our patients as well as our team. And as you saw, we did a big bang of all of our clinics. We had a lot to deal with right after go live, and needed to keep things fairly simple. But we did at go live offer to our patients the ability to view their lab results, view after visit summaries, schedule appointments either by requesting an appointment or self-scheduling, requesting refills of prescription medications, and the ability to send secure messages to providers. And there's, in addition to having the website accessible to them, they also could load an iOS or Android app to their phone and use it there as well. And we got pretty high engagement out of the gate on that, and I'll talk a little bit about the statistics. In December, we turned on e-visits. We had a particular family practice that had been doing e-visits in our previous EMR portal product, and they wanted to be able to continue that, and so we have turned on e-visits for that group. We are not charging for e-visits, and we've not expanded this beyond that point, but it has been a useful learning opportunity for us, and the patients that were using it previously do appreciate the opportunity to continue to use it in that particular practice. In February of 2014, we've turned on access to inpatient and ED records. So that was in preparation for the second quarter of this year, when we were doing our measurement period for the 2014 requirements of stage 1 for the hospital. Required us to be able to offer that up to folks. We offer discharged patients the ability to view their inpatient labs and after visit summaries through that record. And then in June of this year, we added radiology reports. Previously, lab reports were the main, lab results were the main thing that patients could see, and then scheduling of screening mammograms. So what's coming next with our patient portal? We are offering online bill pay in a matter of a few weeks here. We are going to see that also as an opportunity to encourage more use of the EMR of the portal by reaching out to people that may not yet be portal users but who receive bills in the mail, by stuffing that with a flyer that would encourage patients to sign up for paperless billing, which we expect will drive some more activity to the portal. And then in November, we are doing our upgrade to the most current version of our EMR product, which will allow for a higher level of patient data entry into the record, to be able to enter and modify histories, allergies, medication reconciliation records, will of course need to be reviewed by a provider, but it gives us a chance to collect some more changes that the patient may notice that are incorrect in their record. And we hope that it will start to smooth the process of patients arriving for visits by allowing them to complete pre-visit questionnaires. And there's also some capability with that product, which we may not implement right away, but it will come with the capability to integrate with some personal health monitors, speedometers, scales, and so forth. And we'll be looking into that to help patients and our physicians track their care. So how did we get good participation rate with our patient portal? How did we encourage that? Well, first and foremost, we needed our folks to want to do it, to folks to be advocates and champions to our patients, and it really required that they hear that from our executives, that was an important thing to do. And we saw all along as we were implementing the EMR that we had an opportunity to set ourselves apart in this market by offering this product, and so we set that vision with a lot of executive communication about why we wanted that to be successful. But we also had to make sure it wasn't a very difficult thing for our providers to do. And we now have put into our workflow an ability for nurses to see if when they come through in the rooming process, if they don't have an account, and can facilitate activation of that account with the patient in the room with a one click, and then turn it over to the patient to create a username and password. And then if that doesn't happen, or the provider has a meaningfully used dashboard that they're presented with as they wrap up a patient's encounter, and that would show them also if the patient has the account, and we encourage them to encourage the patients and even circle the relevant portion in the after visit summary to point out where their activation code would be when they go to their home and can sign up there. Of course, as I mentioned before, staff engagement is very important. We continue to reinforce it with them. We meet with our users in the ambulatory setting every month. We have user group meetings, and for all of the early meetings and most of the ones since then, we've made sure we've given them feedback on the progress we're making as an organization to the use of our product, and then one of the best ways you can get those employees to encourage the use of the patients is to be users themselves. So we've highly encouraged that employees sign up and use MyChart for their care and the care of their family, so they can see all of its capabilities and really be able to be evangelists for the benefits of that product. And then last, we don't want our folks that we encourage to use to run into a lot of roadblocks and feel like they have no way to get help. And so we do offer a phone line for folks to call when they're having trouble activating their account. We use an outsourced service for that. We get about 600 calls per month. That's held pretty steady from the early days where we didn't have that many people. Now we have over 53,000 users of our portal, but this amount of calls has kind of held steady as people have gotten more familiar with it. It tends to be more of the new patients as we bring them in that are making those calls. Once you're logged in, if you're successfully logged in, there is an ability in the communicate section, messaging section, to request that your message be more of a customer service question or option. And we get about 30 messages a week that come into our staff that point out issues or ask questions about the use of the product that we try to help the patients with through that method as well. Certainly, advertising helped a lot. As I mentioned, we saw this as a competitive differentiator that we wanted to leverage in the market, so we came right out of the gate with our Go Live with billboards, print ads, TV spots, TV interviews of our key staff members, radio spots. And the key thing I just want to say about that is that we made sure it was really part of our broader branding messages, that it wasn't, we didn't want any dissonance between the message we were sending about the organization's quality, service standards, and high touch focus that we have to not to be at odds with what we're trying to say about how they could use technology. And you can see a representative poster to the right of what we would put up in a physician's office for folks to ask about MyChart. We used social media to great effect. Our Facebook page talked up the benefit of the portal. We also engaged in Twitter. When we were doing our EMR Go Live, we were tweeting out the progress we were making and making sure we were folding this message into that conversation. And we've been very surprised by the enthusiastic word of mouth that gets around from our patients to their friends and family, and that's been, I think, a big driver as well. The benefit. It's funny how several of our executives have happened to be in public places and without any prompting happened to overhear somebody saying something to somebody else about how much they love this ability to engage with their physician and their hospital system with this tool. I've included a couple ads if you're interested here on the site. One is an ad which we showed in the general TV rotation, and then the other is something we showed in our own internal TV system. Just short ads that give you a sense of how we tried to communicate that within our broader messages. And this is just some examples of some of the ancillary collateral documents we would provide in brochures to patients, frequently asked questions, folders, brochures, and so forth that would help them get an understanding of what the product does and can do for them. So it's a pretty common misconception, I think, that the patients that use technology are young. I wanted to use this slide to kind of point out that if you first look at the chart, the pie chart on the right, that of the patients between the ages of 60 to 100, we have 35% of our MyChart users are within that age group. We even have, it's too small to make its way onto this slide here, but we did have 12 MyChart users over the age of 100, 12 out of 105 total patients that are MyChart users. So the slide on the left is penetration within those age groups of the patients we have within those age groups, and again, our 60 to 80-year-old folks are the highest penetrated group of people using the portal. So for those that may feel like that's not a group that they can actively target, just wanted to give you a sense of that, and just also point out that as we have those word-of-mouth conversations or we hear feedback from our users, it's often the folks in this area that appreciate it the most. As you can understand, they're high users of healthcare. They often have the most amount of prescriptions that need to be refilled, follow-up appointments that need to be rescheduled, and so having the ability to do that in an online way is very beneficial to them. And that we also do offer the ability to proxy in family members, whether it's a patient's children, to be able to view their records through a proxy request, or whether it's to follow your elderly family members, as if you're an adult who's helping to care for a family member. The ability to proxy that is seen as a really valuable thing. So that falls into this as a little bit as well. This is a particular incentive which I consider maybe even a best practice opportunity, and I wanted to highlight it out specially. This is an opportunity we chose to take to leverage as we tried to improve perception of our access to the community to get to primary care providers. We've been following up with patient survey calls ever since January of this year about their experience with Trinity Mother Francis. So we're calling 100% of new patients. Now we don't, of course, reach all of them. We reach about 45% of them, but it's a significant effort to reach out and call these folks. As you can see, 10 to 12 staff. We call between 8 a.m. to 8 p.m. I think peak time to reach people between 11 to 1, and 5 to 7 p.m. And we aren't primarily calling them about the portal, but it is one of the things we're calling about. We're calling to thank them for their visit, get a sense of their patient satisfaction with the care that they received, and the method, what it took to get in an appointment made and to be reminded of the appointment and so forth. And then we assess their experience at the point of service. But what we chose to do was add on to that conversation an opportunity to assist them with the portal access, to make a point of asking if they have joined a portal, and have they, if not, is there something we can do to help? And so if they do ask for that assistance, we walk them through screens, we assign them a new authorization code if needed, we encourage the use of prescription refills, the self-service aspects of the portal. And to the right, and also as we dug into that, we also came away with data about how each clinic is doing as far as activating their patient base. So the slide to the right shows that of those patients surveyed, over almost 10,000 patients surveyed since January, we've been able to take additional 13% beyond the 27% that had already activated the tool, and get them going and using the tool. And so there's real benefit there. So the last thing, I just want to come around and revisit the issue of our meaningful use Stage 2 requirements, and talk a little bit about how we use the portal to help us in some of these areas. So how we got to Stage 2, we definitely had physician concerns about what this meant to their efficiency, about dealing with secure messages from patients, and did they really want to be in that mode, and is the ability for patients to self-schedule something to be concerned about, so that we had to really work through that and make sure that they understood that the savings they would have on phone calls and the ability to have these kind of asynchronous communication on behalf of the patients, not just synchronous, where they have to engage in a phone call and in order to get their need achieved, was efficient for everybody. To those that continue to struggle with that or not keep up with their patient requests, we do have monitoring ability to see if in-basket messages are not being handled and intervene from an operational perspective, and operations has incorporated that review into their quality committee meetings to make sure that it's getting the visibility it needs. We did benefit from something that some large health systems may probably realize already that they have, which is what I call the halo effect. And this basically entails that in a large multi-specialty group like ourselves, all in one EMR, the way that measurement happens on the aspect of 5% of your patients actively engaging with your organization by initiating a message is that if a specialist may not be getting the messages at the same rate, but if that patient has been seen by a primary care provider also within the system, and that primary care provider has been receiving the queries or the messages, that gets counted towards the specialists' numbers as well. And so by having such a large base of patients and a large primary care provider network, we were able to kind of have a rising tide that kind of lifted all the boats across the finish line for that measure of the 5% engagement with the patients. And then the last thing on the meaningful use attestation measure we had to make sure we took care of, which was generating patient reminders to the patient's preferred method of contact. And for those that had a preferred contact via the portal, we issued reminders about colonoscopies, mammography follow-up appointments, and then something we called summer safety tips about sunscreen and mosquito risks and so forth. And we did that during our attestation period in order to satisfy that requirement. So with that, I just will hand it over to Anthony and look forward to answering whatever questions you may have.
Very good, Jeff. Thank you so much for that presentation, and we're looking forward to the Q&A. So now, without further delay, we're going to turn it over to Doug Bean, VP of Patient Engagement with our sponsor, Relay Health. Doug?
Great. Thank you, and good job, Jeff. And what we wanted to talk about today is Jeff did a really good job talking about Meaningful Use 2 and their patient portal and how they've achieved success. As you know, patient engagement is one of those industry terms that has multiple definitions, and right now it's definitely all about Meaningful Use 2. But as we take a step back and look forward, there are a number of different things to be thinking about when you're developing your patient engagement strategy. And we wanted to talk about and share some of the insights that we've gleaned from our ongoing efforts to truly understand the voice of the market and the voice of our customers, and really kind of punctuate some of the key challenges to be considering and factoring into your long-term patient engagement strategies as you move forward. One of the key insights is, if you think about the way the market is moving right now, there are hundreds of different vendors out there offering, whether it's patient portal or digital health solutions, and they come across very compelling as far as their feature sets. And we also talk about an industry who aspires to deliver value-based care. And if you think about these tools and these aspirations, one of the biggest problems is actually capturing the clinical information and connecting the information so it's actually usable, where you could do the analysis, you could do the risk management, those types of things. And so some of those challenges are you have these siloed health systems, or whether it's siloed health systems in and of itself, or just the health community in which the health systems live. And the information tends to be trapped in multiple technology platforms. If you look at a recent class study on the patient portal market, the number one challenge or one problem that health systems are trying to solve in their selection criteria for their patient portal or patient engagement partner is a level of integration across the multiple EMR systems. They're ultimately trying to develop that single view of a patient's health, not only for the care team, but if you think about a consumer or a patient in their daily lives, they're looking for convenience. They're not out there looking for the ability to multi-manage multiple patient portal applications and aggregate their own personal information. It's just not going to happen. And so, with that, we see there's a big opportunity because at this point, based on the class data, there's only 11% of health systems are actually pulling information from multiple EMR systems into that single view. So we see that as a big opportunity. But to achieve that opportunity, there's a lot of problems that health systems need to overcome. Looking from other data sources to really kind of dimensionalize the challenge or the problem, on average, in their lifetime, patients see almost 19 doctors at any given time, which tend to be on different systems in and of themselves. And that number increases to an average of 28 providers as we get older. And so, as you can see, there's a big opportunity to take all these different physicians and think of them as data sources and try to figure out how do we integrate these different data sources across these multiple providers and create that single view on behalf of our patients and provide that level of convenience. The problem gets exacerbated when you think about the technology landscape. When we talk to our customers, anecdotally, we're getting feedback there are at least 5, if not up to 50, different EMR technology systems within their overall technology ecosystem, which really makes it hard to connect and to create that single source of truth as it relates to your health information. And as we think about how the industry is evolving and trying to adapt its business model to ultimately achieve that more value-based care approach, we're seeing a lot of consolidation in the industry. And these health systems that are either creating strategic alliances within their communities or even acquiring other health systems to achieve that scale and strategic advantage, they're not looking to rip and replace those systems. Rather, they're looking to get as much value out of those systems and get them to talk and get them to be integrated to create that single view. When we think about meaningful use 2 and then now the likelihood of meaningful use 3 involving a lot more patient-generated information, the challenge becomes even more complex in the sense that right now, whether it's iOS or Android, you've got over 50,000 different health and wellness-related apps that are available to be downloaded today. There are about at least 300 different patient portal vendors out there that are offering different types of things to enable patient engagement, which is only going to exacerbate the problem. So it's not just the clinical data; it's also going to be the patient-generated data that care teams are going to need to coordinate care and to deliver value-based benefits in the future. So once you're able to actually integrate all this information into that single view, we think there's a lot of exciting things that can be done within a health system to really engage your patient population, drive down the cost of care, and improve the quality of care. A couple of concepts that we see thinking about is this notion of creating this portal hub where the health system itself is creating that central place for their patients to go. Much like what Jeff was talking about earlier, what Trinity is doing, is that central place where they can get all the information, access to the entire care team, and engage with them and actually collaborate upon their care. The other opportunity is to, with those trusted application or other technology vendors, how can you aggregate those into one single view so the patient is not burdened with trying to manage all these different touch points in their life around their care. And then ultimately, health systems have an opportunity to actually become more of a trusted source, more relevant to consumers and patients in their daily lives, not just in the setting of care in of itself. There's actually a lot more that can be done in improving the health and overall patient engagement in their own health between the different settings of care. And how can that health system become relevant and trusted source for everything related to their patient care? And these are the kinds of things that we're thinking about and sharing with our customers. And with 5 minutes, you really can't get deep, but I do appreciate the opportunity to share some of these insights, and would be happy to follow up and provide any answers to questions and field any suggestions. So thank you. And Anthony, I think I'll pass it back to you.
Very good. Well, thank you very much, Doug. And now we have time for some Q&A with Jeff. Jeff, let me ask you one to get us started. CIOs are used to putting in technology to support the business processes, to making sure the organization is handling the meaningful use requirements. You could be tempting to say, hey, I set up a portal and that's my job. But from your presentation, it seems quite clear that if you don't have a robust marketing plan and some money behind it, you're not going to get anywhere with this. So talk to me about how the CIO, or where the CIO's role is, where it starts, where it stops, and what are the other hospital departments, such as marketing or HR, that the CIO needs to work with if they're going to have success with the patient engagement?
Yeah, that's a great question. My partnership was very strong with our chief marketing officer here. As I pointed out, though, it really stemmed from our senior executive's vision that this was going to be the differentiator, and that was communicated to Darren, the marketing officer, to say, how are we going to leverage this? How are we going to work it into our other branding messages, that this is just one more component of how we reach out and take care of folks. So typically the CIO is called upon to be the translator of the technology into the business and to help bridge that gap. And that was really how he and I worked together on that. What are the best aspects of this to communicate? What through his research and focus groups, what are some of the things, the functionality that the patients are most interested in wanting, and can we accelerate the bringing of those functions back to them? So that's where I think my partnership was the strongest as far as the other functions within the organization. But certainly, as I said before, it all stemmed from the senior executive's vision as well.
What was the most difficult roadblock in your whole strategic patient engagement implementation, and how did your team solve it? How long did it take?
Boy, that's a great question. Trying to think.
Maybe not the most. To start off with a difficult one. Maybe that's easier.
A difficult one. Yeah, I mean, we certainly had our issues with reporting out. Trusting the reports that we got on, understanding what went into determining how many of our patients were activated on the EMR. Was it a percentage of all of the patients in the system? Is it a percentage of those that have been seen in the last 90 days? And so different numbers would get thrown around, and they'd be based on different numerators and denominators. And so really the trick there was to standardize upon, the appropriate one, and then to be very clear in communicating those numbers around. And then working with the vendor, as one of the challenges we had, I'm sure others as well, is as the 2014 requirements for meaningful use had come about, and there was a lot of catching up on the EMR vendor side to implement the functionality that's necessary to meet that. There's also a lot of catching up on writing the necessary reports. And we seemed like there was a point where we were receiving system updates from the vendor almost every week or every other week that were updates to our reporting, which really hampered our ability to get a sense that we were measuring things correctly and that we were on track as we were approaching the start of our reporting period. But we did stabilize in that area before our reporting period started in April, and I think otherwise I think we would have been very nervous about whether we were going to complete it within that reporting period and could trust the data, because nothing it's almost worse than not getting the money is to get the money and then have it taken away in an audit if you can't justify your methodology for the validity of the reports.
That certainly sounds unpleasant. And we've done events about MU audits, so we know what you're talking about. Please provide more details on your patient navigators, nurses, community organizations. I think it's supposed to be mHealth tools for the navigators, home health devices for chronic care, and to avoid 30-day readmissions. Right.
So the whole population health management is something we've really been accelerating. We're not in an area yet that is made the conversion from volume to value. ACOs are not prevalent around this part of East Texas. However, we do want to be efficient with the care of our own employed population base, because we do self-insure those employees and dependents, and so that's a group for which we've put a lot of attention into segmenting into the folks that are higher risk and need follow-up care. So we do have both care coordinators and nurse navigators focused on following up with those patients and making sure that they're having the necessary care. We've entered into a couple of per patient per month population management contracts with a couple of the payers in the area on a kind of a limited set of their populations. It's been a good experiment. Does require us, of course, to deliver on what is expected of that, where we give them a higher level of follow-up care, and thankfully it kind of aligns pretty closely with what we're doing with our own patient base, so we're able to leverage the same care coordinators and nurse navigators at that population. But we'll obviously have to scale that considerably if it starts to scale up to much larger populations than we currently have.
Very good. We have time for one more question. How long did it take for you to get patient engagement up to the 5% meaningful use thresholds from the first implementation? So how long from that first implementation did it take?
It's a good question. I may not have the exact numbers you're looking for. I know that we got 15% penetration of our patient base by the end of May 2013. So within 8 months of our implementation, we had gotten 15% of our patient base as defined by patients who had been seen by one of our providers in the previous 12 months and who had activated the EMR. And again, I should say ambulatory patients who had had an ambulatory encounter in the last 12 months. We are now over 31% of that a year and a half later. The 5% threshold, if I recall, as we measured it against our physicians one by one, we had probably more than 80% of the physicians who had reached the threshold as far as their active engagement with, not necessarily active engagement, but who had activated. We certainly, that 31% has some that are really high, others that are really low, and that really came down to the physician emphasis in that office and their office staff's emphasis as the patients were rooming and then rolling out. And we had to, through our monitoring, had to make a push in those areas to say, this is really important and you need to get these folks on. As for the 5% active engagement and sending the messages, that I don't have the breakdown on. But as I said before, there were some that would not have met that threshold if it was purely based on their patient, their specific patients messaging them about their specific care with that specific physician. But through the way that the measurement is based on whether the physician has been engaging with their care team, the credit that they received was enough to bring all but a few over that threshold.
Excellent, very, very good. Well, thank you so much, Jeff, for the great presentation and the excellent Q&A. As I mentioned, folks, you'll receive an email when our archive recording is ready and a separate registration is required. I want to thank Doug Bean and Relay Health for sponsoring this event and making it possible. If you hold the CHIME CHCIO certification, attending our events gets you 1 CEU for each event attended. So if you've asked us to report that for you, we will. If you have not, don't forget to contact CHIME. Questions or comments, please contact me and go to our website to see our last 12 months of archived events and our upcoming events that you can sign up for. So with that, I want to again thank Doug and Jeff and everybody. You have a wonderful day. Thank you.
Thanks.